the agenda. So we've got this month's dashboard spotlight that I'll move on to shortly, and then the chunk of today we're having a conversation with. So we've got Raza and Jag here with us today, who will do intros shortly, and the topic of this session is really around the PPIE approach that you might be able to take around this work. So we've done a session on this previously, but I think hearing some sort of live examples would be a really useful way to get a better understanding of how we might involve this work with CVDAction. So thanks, Jag and Raza, for coming along. And then there's, following on from that, there'll just be a short activity, some questions that I shared around yesterday, just to sort of get you thinking around how you might want to start this work if you haven't already, and we can sort of take those in breakout rooms or discuss as a group of how you might want to get this piece of work moving. So, and A or B at the end. So if anyone's got anything they want to add particularly, then please let me know and we can address that at the end. So first of all, we've got the dashboard feature spotlight. So this month I wanted to flag the whole help panel, but specifically this button that's circled on the right hand side. So hopefully this is what your dashboards look like. Obviously you've got the home page and then the separate pages for each of the high risk conditions. On this example, we've selected the hypertension page, and then if you go onto the help panel, this top box here will highlight the next steps for each of the clinical conditions. So you'll click that and you'll get a nice overlay. So obviously this one's specifically for hypertension because we're on the hypertension page. And I think it's a really useful sort of quick reference guide of what you might want to do for sort of specific cohorts of patients who are being flagged within the dashboard. Obviously we've got sort of the addressing comorbidities here, so CKD and hypertension, AF and detection and hypertension as well. So it's a useful quick reference guide. And then obviously some of these parts allude to navigating to the other resource tab on the resource button on the help tab, which is this button down here. So you'll click either the link or the information depending on what you're trying to access, and the links, the link tab will take you through to useful links like NICE guidance and other things related to that specific condition. And the information button at the bottom will show you all of the indicators that are accounted for within that page on the dashboard. So help panel, it's not just to tell you how to do things, there's some really useful information in there bespoke to each of the conditions. So make sure you're accessing that along with the data in the dashboard itself. Does anyone have any questions specifically about that piece before we move on? Hopefully it's all very intuitive, and I'm hoping you've all found that yourselves. But yeah, we'll endeavour to keep pointing out useful examples of things you can be doing with the dashboard. Great. Moving on then to the conversation with. So obviously I said we've got Raza and Jag with us here to talk through their PPIE approach within their demonstrator site. So I'll start with some intros. Raza, would you like to introduce yourself, please?
Yeah, hi, I'm Raza Tuesday. I'm a GP in Wallington and joint CD of Wallington PCN. I'm also the clinical IT lead for Southern PCN, and I've been involved with this project last few months. Really excited about what we're trying to offer. I've also got a software development background. I've got an MSc in IT and involved with software development on the English Partner Program for a few years, but now focusing more on local products. So really keen for this.
Thank you. And Jag.
Hi, I'm Jag Kumar. I'm head of new business for certain PCNs. We're really interested in all things CVD related, prevention and lifestyle intervention. So we're really pleased to be working on this. We think it's a real game changer.
Perfect, thank you. So I've got some questions. Obviously, we'll run through first, and then as you're listening along, if you have any questions specifically for Raza and Jag, then feel free to put them in the chat, and we'll come to sort of a general questions round at the end, so we can address anything. Or if you want to ask directly, then you can put your hand up. I'm sure we can find a sensible point to stop and address those. So Raza and Jag, do you want to start with giving us a bit of an outline of how you approach patient engagement across Sutton primary care networks generally?
Yeah, so I guess we've approached this project and this kind of conundrum around patient involvement is really going to help us to improve the quality and outcomes by helping us understand what works and what doesn't work. And when you're doing something new, having that view in terms of what it's like to go through access, experience, and come out the other end of a patient journey is really powerful. And I think sometimes patients might tell us stuff that we haven't always thought about, and sometimes some of our I can speak from experience of what I might think might be a great idea. Patients might think, no. So it's finding that right balance. And just a little bit of background in terms of our model and us as an organisation. So we're Sutton PCNs. We support 4 PCNs across Sutton, which is the whole borough. Our model in terms of CVDAction involves us running centralised clinics that will support 14 practices in delivering CVD multi-morbidity risk assessments. And in terms of where we're at in terms of the delivery stage, we're at the early stages of planning. We've started running our searches, and we're just in the process of getting that data transferred into Power BI. And what we're going to talk through today will be around our plans around patient and public involvement. Harry, would you mind please projecting the slide? Thank you, Rasa.
Yeah, so we mocked up something quickly, just a general overview, just gives some idea of conceptually how we're approaching this interesting subject about patient experience. As we know, we're now into the realm of user-led services and user-led products, and we're trying to get a system in place that starts off with the user and ends up with the user. So the idea really is to try and define your population first, try and tailor make the experience of service you're providing based on the kind of clientele and the type of user group that you're focusing on to manage the demand, the capacity of that service. So what we plan to do first is define a population. I think the main focus is going to be on hypertension and CVD, but it's actually more complex than that, because within that we're also looking at deprived areas, BAME, SMI, LD groups. So we're going to do some analysis on subgroups with the main aim to look and see where we compare to the SWL average and national average, and see where the outlying areas are, and then maybe focus on those more for this kind of projects. Once we've defined our population using data and demographics, it's a matter of trying to invite a group of select patients that will actually be involved with this process, either through patient participation groups, through people that we know, based on asking surgeries who would be interested in what we're trying to do, and then group them together and have some kind of like workshop initially to then show them the outline of our model. Now, the general model is around an eHub system, so we're going to centralize all the recall into 4 main eHubs that we have around Sutton. So naturally, the main areas that we'll be discussing within these workshops will be distance to the centre, access, for example, weekend clinics. And as the workshop evolves, we'll explore other areas that we haven't thought about, which we need to implement within the first prototype model. Once we've done that, it's a matter of then focusing on iterating on that process. But I'll hand over to Jag for the next section.
Or you're on mute, Jag.
Sorry. Yeah, so I guess the next question was around how we would recruit patients and publics from these communities into kind of the work that we'd like to do with them. And to drawing upon what Risa just said around some of the areas that we're interested in, there'll be some other bits along the patient journey that we really need to think about engaging with different cohorts. So we're really keen to engage with the people that we contact and take up the offer of a multi-morbidity CVD risk assessment, and understand why they took that offer, what their experiences of care was like in the past, and actually what was it like accessing this clinic, what was good, what could have been better. Another key area is the people that say decline the offer of coming into our clinic or accept and DNA. That's really important, because those are the people in some ways that actually the offer or the offer that we've given them perhaps hasn't worked quite right for them. So we're keen to understand why is that? What could we do differently? Is it a logistical thing, like distance to for them in terms of traveling, a time thing, or something else that kind of has led to them saying, actually, no, we don't want to take part in this. There'll also be, so we would use the call and recall team to kind of pick up on those two cohorts. Another area that I think that would be really interesting to explore is once people have come out the other end, and if we refer them to some lifestyle services, that might be another juncture whereby we start to invite people's feedback at that point of the pathway to say, well, what was the lifestyle services like? What would you like to do more of? What would you like to do less of? What other options could there be? And I think I'll just pass over to Raza in relation to the link to the integrated neighbourhood teams.
Yes, another hat I have on is leading on into neighbourhood teams in my local area, and there's a whole host of voluntary sector organisations that we can access and tap into in order to both design the actual overarching mapping of what we're trying to achieve, the service itself, but also get feedback and link into when we need to iterate on it and try and improve upon it. So we're looking at different areas that we're looking at, especially around CVD and health style living, which we will be looking at with our local services, which is quite exciting as well.
I think that the next question was around what might your activity approach look like, for example, online surveys, virtual workshops. I think the key point for me here is we like to create spaces where patients feel comfortable and we perhaps feel a little bit less comfortable. And if we're doing that, we know that we're speaking to the patient needs. We're creating spaces that they feel confident and comfortable in saying, talking about their experiences. And some of that might look like running some focus groups, having potentially individual one-to-one interviews, having some questionnaires, or doing an interactive workshop. And as Raza alluded to earlier, we're really keen to kind of create some kind of co-production panel whereby we can, we know that as we start to deliver this, there'll be little bumps in the road that we'll come up against, and so we can go and check out with the patients, actually, well, this is happening, what do you think could be causing this? Or use that as a juncture of inviting those people into, or consulting with them, say, look, Mr. Smith, you DNA'd, or you didn't attend your follow-up appointment, what's going on? So that we can start to look at kind of iterate in real time and understand what the barriers are, and also have that perspective that will challenge us, because I think sometimes where as professionals it makes perfect sense to us, but it's really important that we kind of are held to account by our patients. There's also another idea, and I'm not sure, I'd really like to do this, and I hope we can, but it's also how comfortable people feel, but it's about having some video feedback. So actually creating some short vox pops videos of actually, well, you've been to your clinic, the nurse or clinician have to just, they do look at, a 2-minute video on actually what happened today, what was good, what could have been better. And I think sometimes having that real-time feedback is really important. I think it just helps to keep us focused. Raza, I'll pass over to you for the next one.
I think the key take-home message for us is that we need to get away from having static services that just run and then patients work around that. In this new world of user-led kind of model, we need to create a dynamic, interactive service model and constantly get feedback from the user in order to see how we can change and make it better. And that's really kind of key on what we're trying to do. And the different avenues that Jag alluded to as to how to get that feedback. So, post implementation, user groups, questionnaires, and act upon them, and have like another group after to say, how can we improve what we're doing in a better way in order to serve the user and so the population. It kind of does get complicated because you're looking at other kind of areas, so multi-morbidity clinics. Make sure they're not confusing, make sure we're perceived well in what we're trying to do, make sure we manage the user in a way that's friendly and actually is simple in the way that they approach the service. So they go back and say, I felt as if I could change the way that I managed my condition based on the way that the interaction occurred within that service. Also how to communicate risk, secondary prevention, trying to focus on the user on trying to prevent them from going further sort of upstream in terms of their condition, and also lifestyle intervention changes, how we can link in with other services based on user needs. So they say, it wouldn't be good if we had like a weight management service within our e-hubs. So then it's just managed building that up and building up the requirement based on what the user experience and what their need is, rather than just having a static model that you know they live with or they don't. And I think that's really the key of how we're trying to approach the way we're working at the moment and moving forward with these type of projects.
Thank you, Raza. There's just a few things I wanted to pick up on there that sound really exciting. I think, obviously, first of all, to try and move away from the static approach is so key because, yeah, there's no sort of one size fits all approach, and you know, there's so much diversity in how people access services. It's almost you know, ridiculous to think that everyone accesses through the traditional means. So I think there is a real need to iterate and reinvent how we're engaging with communities across the board. I liked your point around taking an iterative approach to the patient feedback as well. So obviously you've listed a few means of how you'll be engaging with these patients around, so whether it was like one-to-one interviews or focus groups, but it sounds like you've really got some space to even tweak those approaches. So if something's not working there, obviously if they've not attended their appointments for whatever reason, there's chances that they might not interact with the sort of aftercare outreach as well. So it sounds like you've sort of got considerations for how you'll be reaching these cohorts.
I think the other key thing is trying to get localism in it as well, because as we move forward, we've got 4 hubs and basically 4 areas in the PCNs, and let's say one area is more deprived in a certain area or weight's more of an issue. So it's just a matter of linking with the INTs to try and get some more weight management focused service for that area, and that comes with looking at the data and looking at patient feedback as well. Or some areas, you know, they're more of a BAME population, so trying to manage it with more people that understand the language barriers as well. So, you know, it's just trying to get that going, but working on a model that is basic but works, and then evolving it in different areas, just trying to have that localism agenda, and that's where INTs come in as well. So we're really keen on working with that.
I think also, just to add, I think as we go through this journey and we start to engage with different types of patient cohorts, their needs are going to be different, but it allows us to segment and kind of proactively think about how we might change our approach in terms of call and recall, or what happens at the clinic, or what lifestyle options there might be available based on that kind of, you know, demographic factors like age, gender, ethnicity, deprivation, or if someone has got an SMI or LD need. Actually, that might shape some of the ways in which they experience and get targeted throughout the service. And I think if we can do that, it will help to kind of create a bigger impact, I think, in terms of what works for each group.
So the way we want to operationalize this is once we get user feedback, have a regular kind of ops meeting with the ops team, and go with feedback questions and see how we can tweak the model to then involve other services, for example, or make sure we improve the timings or whatever. Just so, you know, and basically evolve the product through the user. I think that's the key thing. But operationalize it with the ops team to make sure that they're on board with this.
That's really exciting, and that's like a tight feedback loop that you're obviously building into this process, which is really helpful, because again, it allows for iteration. Are you planning to do that with the sort of lived experience panel or the board of patients that you'll be collating?
Yeah, I think it would be, I guess we'd have to kind of merge the feedback we get from them and take it to the ops meeting. And I guess an overall vision might be, actually, can we merge the two or have some joint meetings, have everyone in the room? But I think we have to kind of step to that in an iterative fashion, just so that the patients feel comfortable and confident. And I think initially
I'd have both of them together and then look at the questionnaires and then see what their feelings are on it. And then change it accordingly, try and be open and transparent with everything, and then manage the ops team with the patient's expert panel there to try and move the model forward. I think that's something we're looking at.
Great. I think that all of that process sounds really exciting. So I think that leads us on nicely then to the sort of final question, which is around what were you aiming to do with the information you collect, and sort of what impact would you like to see from this process that you're going through?
So the key really is choosing the right patient, right? And that kind of comes with the data that you choose. So it's important that once you get the data, we're trying to sort of, focus on the right patient to get the right outcomes. So not only, for example, if they have a high blood pressure, do they smoke? Is their BMI high? Are there other kind of risk factors around them? So that the idea is that by focusing on the risk stratified patients, you're getting the better outcomes for the same amount of work, if that makes sense. So that's the kind of the key area that we're looking at. So it kind of, like I said, starts with the user and the data, that ends with them as well. And then as we evolve, we'll kind of like improve upon that.
And then what I guess just to build on that, there may be some adjustments that we start to make around the call and recall processes that we utilize to kind of get patients in. There may also be some stuff around actually how do the things that we do within the clinic, because actually going from what patients have experienced in the past to what we're doing now, actually, is there too much good information that they might be bombarded with at that clinic? Is there anything that we can do to help relay better the communication of risk, or the importance of said medical optimization or making lifestyle changes, and kind of basically improving kind of secondary prevention? And then I guess there's also that final stage around lifestyle, because I think you've got the medical optimization, but to get that real step change, and also that kind of movement into kind of more activated patient that's more in tune to self-care, how do we start to have those conversations around lifestyle? And we're really interested in potentially looking at things around technology and health coaching as a way of kind of disrupting some of the patterns that people are in, but also giving health professionals additional information to kind of provide support and challenge the patients around lifestyles, what their barriers might be, if there's certain times in the day where blood sugars rise, or exercises, certain weeks where they're not exercising, we can get that data through kind of things like Freestyle Libre 2, or wearables like Fitbit and so forth. So that would be a really interesting area to explore as well.
And also, just to add to that, that's why I like the CVDAction panel, because it kind of focuses on the risk rather than just numbers, and that's the key. We're trying to focus on the right population, and this panel helps us achieve that through grouping patients up with certain areas that we can then hone our skills on, and really kind of get down to important bite-sized chunks that we can look at. The caveat around this, and this around the rehab potential of the patient. Some patients, they just don't want to know, and you can have the highest risk, but they're just not interested. And it's just a matter of appreciating that as well, and finding out what the metrics are to try and enable them to then engage more with the service. But it's a matter of trying to focus on the right patient as well that way.
Absolutely, thank you. And just to touch on again, I think you'd said sort of about how you're going to be collating these patients initially. Are you planning on using the dashboard to sort of drive some of that that patient gathering as well? Because obviously you'll have the patients that come to you through the pathway, but you might be able to do a bit of front-loaded work where they can be identified through the dashboard using the demographic functions, for example.
Absolutely.
So I mean, we're looking at this, and what worked well with our previous model was actually only using patients from risk stratified data, but at least initially anyway, because when I'm in a GP practice and I see a patient, I don't know their risk potentially. I don't know, what their how much burden there are on the NHS. It's very difficult to tell. So sometimes patients go through a system that the GP, I think they should, but in actual fact, for pure kind of, risk point of view, they don't. So trusting the model, I think, works. And from a practice point of view, as long as they're aware that the patients are being offloaded to the service, I think they're happy. And from that point of view, one thing I forgot to mention, I think very important, is comms, right? So not only comms to the patients, but comms to the practices as well. around how you're going to manage the patient and their journey, and just to have that development, trust and relationship to try and help us, manage the patient together collaboratively rather than competitively.
I think also the demographic factor on the links on the dashboard just means that we can easily get through to some key groups around, particularly around those in the most deprived backgrounds, those from BME backgrounds, and also those with SMI and LD needs, because actually we know just those groups would historically and often face barriers to accessing services that might require something different. So yeah, it's good that the dashboard allows us to kind of segment those patients from the onset.
Great, that sounds really exciting. Raza, just to pick up on the point you made around making sure the practices are obviously aware of this work and the part they have to play. I think that would be a good opportunity to incorporate some of the wider practice care framework resources that are available. So we've got a library of education resources, as well as self-management and behaviour change resources for patients as well. So throughout this work, it would be good if you could try and incorporate those things. And obviously at UCL Partners, we would play a part in supporting the rollout and implementation of those pieces as well, whether it's education for staff or just making you aware of the particular resources that you can deploy for patients.
Yeah, absolutely. I think I'd love to be on board and use what's already out there already and try and drive that through. I think the key, like I said, we're trying to do is be collaborative with the messaging for the patient to say, listen, you can still go to your practice, but we have weekend clinics in a local hub. And if you find that's easier for you, then come to us as well, and try and work with the messaging so that we're not confusing the patient about where they should go, if that makes sense. And then the practice can also have that message as well. So that's kind of key as well. I think Ben had an interesting question, which always, especially with the cholesterol target as well, a big issue, isn't it?
Yeah, thank you, Ben. I'll read it out for the recording if you don't mind. So Ben's asked, have you thought specifically about how we address patients' reluctance to start statins? I would say the biggest barrier to optimizing patients with higher CVD risk and improving our dashboard performance.
I think it goes back to the point we made around what do you do to patients that don't want to know, right? Or have side effects medications that make them reduce their increase their Q risk, for example, or increase their risk. And I think that it's just a matter of finding out why they don't take the medication and the different reasons for that. And if it is a side effect issue, is it because they had a friend that didn't take it or had side effects and they don't want to try it? Have we explored all options? Is etamide's an option for patients that are not taking it? Have we explored other statins as well? Just trying to be more depth around the reasons why they're doing it. It's a cultural thing, and try and untap that. The problem is in a 10-minute consultation, you don't have the time to do that kind of stuff. So we're hoping that this service will be able to give more time to explore that, and maybe look at a group that actually specifically have issues with statins that have a high cholesterol, and try and manage them with diet and exercise through the health well-being coaches. They're finding other mechanisms to try and get their cholesterol down that not necessarily is via statin, if that makes sense. So different ways of doing it, but I totally agree. It's that age-old dilemma around how do you manage patients that don't want help. And yeah, it can be very difficult to try and focus on those, I know. In the end, we're only trying to manage 20 to 30% of the problem, not 100% of the problem. So we're hoping that we're going to manage 20 or 30% that actually want to change rather than, the rest that don't.
So any progress is good progress, isn't it? I guess.
Exactly, yeah. Exactly.
Jag, do you want to come in there? I thought you might wanted to add something. Sorry, you're on mute.
It's a tough one, isn't it? And I guess the kind of the stuff that's out there on Google and in Daily Mail and general kind of circulation amongst patients sometimes can counteract the kind of medical evidence bit. I think what I said around time is really important, but also I think there'll be other types of ways of explaining the importance of said medication, and we've, I guess if we've got the time plus those additional resources that we can deploy and have different conversations about, hopefully that might help to address some of the needs of these patients. But I think we have to accept that there will be just some patients that they don't want to do that, and we'd have to think of creatively, like Roz said, around the lifestyle interventions. But what this service does is it creates an opportunity to have more space to have these types of conversations. So I think that's going to be really important. So the learning will be immense.
I think the idea is trying to get the vehicle in a place we're good with, and then change the content based on certain assumptions. So it could be that we do a search on those with a high statin based on the CVDAction dashboard that are not controlled, that have side effects medication, and then specifically ask them just what they feel about it, and try and manage them accordingly. Because again, making a bit of difference to that population actually will make a huge difference to the bottom line as well.
Thank you both. Yeah, I think, and just to add as well on the point around, having the tight time constraints in primary care as it is, and only having sort of 15-minute appointments to download all of this information to your patients, as well as trying to do the clinical optimization. I think through CVDAction and working in this way, as you've highlighted, Jag, you're already working with the very high risk patients, and hopefully through risk stratifying and importantly as well optimizing your workforce, so doing the bit that sits alongside the clinical work of sort of reviewing how these patients are being seen traditionally, and perhaps breaking out the high risk patients to be seen by the sort of the prescribing clinical staff, and then the sort of lower risk patients can be worked with by the wider workforce. Hopefully that allows for sort of more opportunity, dare I say more time, because I don't think there's any way of creating more time, but to really be able to ensure that the patients are bought into their journey, and you might end up being able to unlock progress with some of these patients where traditionally in the stereotypical way of working you might not have just had time to do that, or they might not have been engaged in that traditional sort of recall process.
Yeah, we're trying to create like a one-stop shop, if that makes sense, for these type of populations, and try and, instead of let's refer to health and wellbeing coach and come back, let's have them all in these e-hubs together based on the requirements, and then we'll work on them collectively.
Yeah, that's a very sensible way to do it. So you're sort of considering all of the needs before they come in, rather than having to be called in every other month for sort of various conditions.
And if the feedback is we need more of this, then we just adapt the service to make sure we manage it.
Yeah, absolutely. And again, that's where the iteration comes in, isn't it? Just making sure that you're taking a flexible approach to what works well. Great. Okay, so that was all the sort of pre-planned questions we had. So thank you, Roz and Jag, for taking us through those. Just open up to the rest of the room if anyone's got anything to ask specifically or comment on as well. I know we've been talking for a while, so if you still want to have a think, then pop it in the chat perhaps, or you can just get in touch afterwards and let us know if you do have any questions or want to follow up, and I'm sure we can arrange a response. Farwa, you've got your hand up.
Hi, just really to comment, that was such an interesting discussion, and I agree, Rosa. So I think as a jobbing GP, it's really hard to risk stratify the person sitting in front of you, and that's where CVDAction is really going to have. It's going, I see it as a game changer for the future, and I think just in medicine in general, we really underestimate the impact of social determinants of health. So kind of levels of education and the ability that has on health-seeking behaviours or kind of health engagement behaviours. So, the average reading age of adults in England is actually that of a 9-year-old. That's really significant when we think about the instructions that we put on a repeat prescription, or the sort of language that we use. So, yeah, just wanted to comment about that, really. Thank you.
I think that's so important. Right, you know, and I think as we develop the services, the key I think is localism, right? So you're not only risk profiling from the physical metrics, you're actually risk profiling on other social determinants, and then you're adapting the service to accommodate the profile of your local population, and that's what's been missing at the moment in terms of managing these type of long-term conditions. I think moving forward, I hope that we'll be able to sort of do that at a local level, because the main determinant factor of whether engagement occurs is how local the service is, or one of the main ones, to the patient. And if we can try and tailor make it so that in this area this is the main issue, then and adapt the service to manage that need on the social determinant factors, which is very important, and that'll really improve the compliance and improve outcomes. Totally agree.
Yeah, thank you, Paul. I think that's a really important issue and something that could be addressed not in its totality, but definitely as a part of this project. So I think it's important to stress the PPIE aspect of this work can really focus on sort of anything that you deem to be, you know, sort of like an important or localized issue that you've you know, uncovered or something that you want to work with a community to understand better. So that's a great example around, you know, sort of the average reading age being that of a 9-year-old. If that, you know, we could work to identify a community and then who's sort of prevalent in your area and under accessing services, and then if that's the niche you want to work with, then it could be, you know, developing resources that are bespoke to a community that would allow them to gain better access to this service or services as a whole. So we don't need you know, to have like a huge start to end sort of pathway or plan. It could be quite a niche piece of work, but you actually see some real impact on when working with those groups, obviously, albeit identified through the dashboard or sort of known to you already. So yeah, I think that's a really great example. Thank you for highlighting.
And also I'm going to say, discuss the population health management team, because they're going to be keen on a new world of how we intelligently work out what services are available, and they'll have the information to say in your local area these are the main outliers, these are the main issues, so you can evolve those and expand them as you go along. Most areas have that.
Yeah, absolutely. It's another great resource, Raza. Thanks for pointing out. Brilliant. Okay, so if that's the end of the questions for these guys, then we'll move on to the activity portion. So I sent around some questions yesterday. I hope you'd had a chance to look at them and sort of have a think through. We've sort of covered all that in the conversation, so I'll skip over. But these slides we'll share. We'll go out with the recording. We'll send them around to everyone on the invite, and we'll also upload them to the futures page. So if you do want to review the content or rewatch or share the recording with, you know, peers who couldn't be here, then that's fine to do. So yeah, I thought we could spend a bit of time just sort of considering these three sort of key topics. So where could involvement with patients fit into your work? Who to involve in your work, so who could be the right communities to involve, and then how will you incorporate any feedback you receive? So once you've engaged target communities and gathered that feedback, how will you use it to improve your work? So obviously they're sort of meaty topics which will sort of require thought and planning. But I thought obviously having Raza and Jag here and the careful thought that you've put into your plans, it might be useful for us all to sort of think now about how we might want to take a similar approach in our own PCN. So I think rather than going into breakout rooms, it might make sense for us just to stay as a group here. So perhaps should we start with the first one, and we can just have a conversation around that, and then obviously if we get through all of the questions, and that's great, but otherwise we can sort of pick those up another time. So I don't know if you've had a chance others on the call to sort of access the dashboard and really have a look at the demographic data that it presents to you around the cohorts that are being identified. But do you have sort of any early ambitions or thoughts around how you might want to fit patients into your work? So, Farwa, sorry to pick up on the point you've just made, but sort of around the that piece of the average reading age and that sort of thing. Is that a topic that you've been considering?
So that's a statistic that I'm aware of through my teaching role. What I had more been thinking about, so we have very good, we have a very established relationship with our local community health champions. So this was a joint project funded by the local ICB as well as the local authority. And it just so happens that the lead is one of my registered patients. So I have a kind of a very, very good relationship with her. She knows exactly where to find me when she needs me. And it's basically, so the project was based on a very successful health intervention, public health intervention in Brazil, where in one of the very large favelas, I think it is, like the equivalent of our housing estates, they recruited local residents to literally go around and door knock on patients to understand why they had not been engaging with traditional health services and encouraging new mums to get childhood vaccinations done for babies and things. So with the community health champions, they have evolved in the last 2 years, and there's a fantastic suite of activities that they offer, and they've really managed to embed themselves into the local community. So I'm a GP in Roehampton, and I'm CD for one of the PCNs, which is in Roehampton, as a tripartite PCN group who is going to be using the CVDAction dashboard. All of the PCNs have very high levels of socioeconomic deprivation in pockets, so in kind of areas of concentration. And we have community health champions embedded in all 3 of the PCNs. So that's going to be our main avenue of getting involved in the local patient population and how to engage with them. And actually, it would be quite helpful maybe in one of the later calls to understand from PCNs who might be slightly further along in their CVDAction use and kind of project delivery about the stage at which to get these community health champions involved. So it's something I've been thinking about a lot. It's quite interesting, Harry, that you've mentioned the stage particularly, because that's something I'm sort of grappling with. I don't know whether it's, you know, whether it might be worth getting them involved right at the outset to kind of spread word about the project, or to get them involved if we, you know, maybe to start the project, and if we don't have such great uptake, maybe we get them involved to kind of help at that point. Or actually, now that I'm saying it out loud, maybe we should just have them involved at every stage, I suppose. Now that we have the luxury of the time and the funding to be able to give a focused population health approach. So actually, I think I've just talked myself into my own answer there, but I would appreciate colleagues' opinions on this.
Yeah, that's great. We didn't have to do anything, and you figured it all out. So congratulations. I think, yeah, it's a good question about the staging. I think it largely depends on your starting point. So obviously it sounds like you're in a great position of having this pre-built network of colleagues and of like an understanding of your local demographics. If that's not the case, it might be beneficial to sort of bring that resource in early, start to work with patients from the start to really understand, you know, to uncover what you don't know. So it might be that you go out and hold focus groups with prevalent demographics or populations who maybe aren't you know, interacting with their healthcare or you know, have poor adherence or whatever the topic might be that you feel is most prevalent in your area. And that's where you can take in a lot of the intel that will inform then how you build your pathway, or you know, design the service for them to interact with it in a specific way. So I think that's one possible approach. But then you could also, if you've got that sort of base of knowledge, which it seems you have, you could do a lot of the like the pre-work, I would guess, and then once you've got a built proposed pathway, then you can go out and interact with your communities again. So bring them in at that point and say, look, here's what we're proposing, here's what we've got, and here's how we suggest you interact with it. How does that sound? How does that work? Would you work in this way? What would you like to change? So I think at every point is the best time to bring them on, as you've concluded. But yeah, I guess it would be great to hear what others think of that approach specifically. Raza.
Yeah, I think that's brilliant. I think there's a lot of soft intelligence that we need that we haven't got in the system, and that's a problem at the moment. Data's only good as you know, rubbish in, rubbish out, you know, as what it is. And if we can actually get ground floor, you know, intelligence around what the actual needs of the population are, we can then adapt the service in order to accommodate that. And this kind of incentive, I think, would do that. And it's always, you know, you can always guess what's going on. There are a lot of gaps, but actually having people saying this is a problem, we can find solutions to it. Otherwise, we're not hitting it on the head, nail on the head, if that makes sense. They're really good at. Let me know about it. It could be good to sort of get some ideas about, you know, try and get in our local area as well. And likewise, you know, we can share ideas as well. Be good.
Great. I think that would it be sensible, maybe Farwa, unless Ben, if you have got anything that you want to add or come in with, then please by all means do that. But would we be able to just work through the following 2 questions with you, Farwa, perhaps, if that is fine? So
yeah.
obviously, we've just discussed the you have the sort of colleagues in place who you might be able to work with to do this. So when it comes to identifying communities, you said there's sort of like pockets of deprivation spread throughout your geography. Is that you're going to filter by the indices of deprivation? Is that your sort of main plan?
That's going to be our yeah, so we've on the last couple of projects, we found it really helpful and really good kind of long-term preventative value for money to filter patient activity and kind of funding and resource by the core 20+5 population. So it's really helpful that CVDAction, the dashboard, has that ability to filter by levels of deprivation. That's really going to, so we're, you know, kind of going back to the interview answers that I gave. We're going to take a kind of a quartile approach. So we're going to initially filter by deprivation, and then we're going to call and recall focus on the highest deprivation quartile, and then work our way downwards.
Okay, yeah, that's really sensible. So you'll be sort of reaching those communities first, and then working that way. So how do you anticipate that will overlay with the you know, sort of the condition prevalence and the high risk groups? I'm assuming they'll be in the Venn diagram. I'm sure you'll meet a lot of patients who fall into both groups, but then the high risk patients who might be in a lower deprivation quintile. So how are you anticipating you mop those up? Will it just be sort of staged out throughout the project?
So that's a really good question, Harry. And actually, again, kind of thinking on my feet, maybe we need to do 2 different approaches so that we do capture those who are medically highest at risk, as well as those who are highest at risk because of kind of, you know, the socioeconomic deprivation factors. So maybe there's a role for doing a bit of both in tandem. Thinking from my kind of experience, the ones with the high, you know, the multi-morbidity, the lack of engagement, almost always tend to fall into the highest deprivation categories. But we do want to, it would probably be helpful to introduce a safety net to make sure that we don't miss those who are organically highest risk without the deprivation factors.
Yeah, absolutely. I think that's really sensible. And just before I bring you in, Raza, just so on the dashboard, there's the functionality to do just that. Obviously, you'll have the condition filters at the top across the boxes per high risk condition page so you can pre-select the patients that fall into those high risk categories regardless of deprivation. Then you can go on to filter by those demographic filters that we described earlier. One of them being deprivation, and you can just work through the 1 to 5 scaling. You can export a list of patients per list, and then you'll have those cohorts that you've just alluded to sort of ready to work through. So that might be how you could take that tandem approach that you've described. Raza, go on, you've got your hand up.
Yeah, Jack probably fed up me saying this, but I have this saying, which is all roads lead to Rome. Okay, and that's no matter what kind of metric we have, all the population health have these kind of really fancy graphs around different areas, but there are two main factors that always comes up for these type of patients. That's BAME and deprivation index. Always. The problem we have though is not that they're the population, it's why are they the population. I think that's what we're trying to explore and uncover with this. So, trying to break it down in different areas and risk stratify, but having that as a core group to focus on, I think is really important. So, I think that's why I'm really excited by this project.
Yeah, that makes a lot of sense. Thank you, Roz, because you obviously have the clinical work that will be going on, but then I think that's why it's important we've tried to include this PPIE arm of the project. It's about understanding the why and then being able to have an impact on specific situations for certain demographics. So yeah, also, very pleased.
But looking at those two areas as a base, right, and then seeing from the dashboard which, like doing the other way around, seeing the areas and dashboard where the areas of the focus need to be, and then look to try and adapt the services accordingly. That makes sense.
Yeah, absolutely. So then the final piece, obviously, we're sort of short on time, and I wouldn't want to rush through this at all. But so how will you be incorporating the feedback you receive? So again, if I was to sort of talk through your example, really appreciate your sort of candor with all of this. But I think once you've got so you're working with the highest deprivation groups, you'll be working. That's how you'll be sort of like triaging the highest risk cohorts. If you're working with those communities to sort of gather insights and feedback, how will you feed that back into the work you're doing?
Yeah, so one of my motivators for doing the kind of clinical leadership work and participating in the pilot is to try and kind of galvanize some long-term change. So making the case to the powers that be that you can't use universal approaches on these very niche patients who have really different needs and the reasons why their health-seeking behaviors have traditionally just not worked on paper, but it's because we're using approaches that are not suitable for them. So it's really about trying to change the system and to attract more funding and change the design of services.
Yeah, absolutely, and that's such a meaty topic, isn't it? I'm sure there'll be so much rich information that you're able to extract by doing this work that hopefully you'll be able to reflect on the way that things work and how they are. I think just to give a quick summary of the support that UCL Partners, obviously as the partner organisation across this work, is able to provide. We've got PPIE leads in place who can support the breadth of the work that we've obviously described, right from sort of identifying cohorts who you'd want to work with, establishing like problem statements or topics or areas that you'd want to focus on, right through to recruiting the patients, running the focus groups, through the sort of London funding that's available. We're able to give that support. So by all means, please be talking to us throughout this process, and we can, where appropriate, offer the right amount of support to make sure that we are gathering all of this really, really rich information that we'll be able to implement afterwards. Brilliant. So that brings us to time, 2 o'clock. Just a quick run round for any AOBs, if anyone has got anything they want to flag particularly before we close. No, perfect. The only thing from me is just a reminder of the next couple of these community practices. So we've got one in for February and March. I'll just double check that those invites have gone out. So if they're not already in your diary, you should get them shortly. For next month, we were hoping to talk through the sort of practice care approach, obviously based on the practice care frameworks and the wider resources that are available, and how you might incorporate that into your CVDAction program. So we'll be able to give you more information on that shortly. But yeah, unless there's anything else for now, thank you very much, everyone, for your time. Thank you, Raza and Jag, again for coming along and answering those questions. We'll all catch up soon.
Your pleasure. Thank you for inviting us. We appreciate it.